welcome to the Weekend University. My name's Niall, I'm the founder. I'm here with the first speaker, Dr. Janet Feigenbaum. Dr. Janet Feigenbaum is an international consultant trainer in DBT, an associate professor in clinical psychology at UCL, and the clinical lead for the intensive management of personality disorders assessment and recovery team at the North East London Foundation Trust. Janet is the director of the postgraduate certificate in CBT for personality disorder at UCL and provides training, supervision and consultation in DBT and personality disorder service development in the UK, Ireland and Europe. She completed intensive training in DBT in Seattle with Marcia Linehan, the originator of DBT. So, Janet, a warm welcome to the Weekend University. It's great to have you here with us.
Thank you.
And wish you the best of luck.
Great. Thank you very much. So, I've got a very short period of time to introduce you to quite a complex therapy. DBT was developed as an emotion-focused therapy. Marcia Linehan, the originator, identified that CBT wasn't meeting the needs of the individuals. These are suicidal, self-harming, substance misusing, sometimes violent, self-neglecting, difficult to engage clients. That's who we're talking about. In my service, we get told we cherry pick. And I said, yep, if I think a person is likely to die in the next month or two, we'll take them. So, at the very heart of DBT is the biosocial model of borderline personality disorder, or you might want to call it emotionally unstable personality disorder. The idea is that individuals have a biological vulnerability to emotions, which I'm going to explain. And that transacts with an invalidating environment. The overwhelming majority of people with personality disorder, borderline personality disorder, have had some sort of trauma history. They've been abused, neglected, they've been raped, they've been bullied, and those are the invalidating environments. However, it can also be an environment that just doesn't understand their emotional vulnerability. And that leads to more emotional dysregulation. So let me tell you about this emotional dysregulation. This is what it's like for these individuals. I share this with my patients, with their families, with social workers, with teachers, with anybody who will listen to me. This is the essential understanding from the DBT perspective why people do what they do, but it's also based on the evidence base. So up here is the strength of emotion, how strong it is, and along the base is time. Here, a cue comes into the amygdala. The amygdala is a small almond-shaped piece of your brain in your temporal lobes, just behind the ears and inside. The amygdala is the emotion cue center. So it takes information from the senses, or it takes information from memories, thoughts, images, and it decides what emotion it's going to set off. Because the word emotion means to elicit motion. It's to make movement happen. We have emotions that get us away from things that decrease our survival and closer to things that increase our survival. So the amygdala, first thing it does is send a signal down to the midbrain to say, right, heart, get going, start pumping, get a bit more oxygen because we're about to move. And it sends a signal to the parietal lobe saying, right, which muscles are going to move? And we will get on to what emotions, what those movements are. So the emotion then goes up. Now, in some people, it goes up and comes down 20 minutes, maybe 30 minutes. Emotion goes up and comes down. In the people who are emotionally vulnerable, the emotion goes up much, much faster. They will say to you, I was fine, and then I was despairing. I was fine, and I was enraged. They say, my emotions go like 0 to 100. And it shoots straight up and stays up much, much longer. Now, there's another part of the brain that's involved, and that's the frontal lobes. The frontal lobes kick in a little bit slower than the amygdala. The amygdala says, get going right away. And then the frontal lobes come in behind that saying, wait a minute. Does it fit the facts? Is it the right time? Is it the right amount of emotion? Now, what's so bad about that? Well, there's this thing called the dotted line. And when our emotions go above the dotted line, we stop being able to think fully. Our information processing systems shut down a bit. Now, that makes perfect sense. If a tiger came in the back of this lecture theater that hadn't eaten in 3 weeks, we don't all want to sit here and think about it. How did a tiger get to Greenwich on a Sunday? Is it a person in a costume? Is it a hologram? Are we all collectively hallucinating? If we sat and thought about it, we'd be eaten. What we want is for our amygdala to tell us to get to safety, and when we're in safety, we can pause and think, wait a minute, this doesn't make any sense. So all brains do that. But most people don't go above the dotted line very often. You've all probably been there at least once in your life. Maybe minutes before an important exam, where you look at the exam paper and think, I don't know anything anymore. Or moments before an interview for a job you really wanted, or some other instance where something happens that's highly threatening. You stop being able to think straight, remembering what you've done in the past, being able to problem solve. Now, what do we call it when you're acting without thinking? Well, that's impulsivity, acting without thinking. And we've all got moments of that. We've all sent that email we wish we hadn't sent, or said something in the heat of an argument we wish we hadn't said. We all get up there. But most people who aren't emotionally vulnerable don't go up above the dotted line very often. Maybe once or twice a year at most. But the individuals that DBT was designed for go up there daily. They're up in that, can't think straight, just do what you need to do. And think about the consequences later. Well, the other problem with being above the dotted line is it hurts. It really hurts to be up there. And emotional pain is processed in the same pathways as physical pain. Now, pain is a signal to stop doing what you're doing. If I, in bare feet, step on a sharp stone, it tells me to pull my foot away. So when people are above the dotted line, they're in emotional pain and they're desperate to get away. Well, what are the quickest ways to get away? Well, if you cut yourself, you drop straight to baseline. And that's what the people we work with say. As soon as I cut myself, my body relaxed, my mind slowed down, my emotions went down. Attempting suicide drops you down. Drugs and alcohol drop you down, even before they hit the bloodstream, assuming that you've already had some experience of drugs and alcohol. Planning your suicide drops you down. Hitting someone or breaking something drops you down. So all the things that we're working with our clients with are all solutions to the problem of pain. It makes perfect sense why they do what they do. Now, so they drop down to baseline, and then a few minutes later, a few hours later, they think, oh no, people will get cross with me for doing this. Now I've got new scars. Now I've done this. I hate myself. I'm useless. And all of those kind of thoughts and the response of the environment become cues to send them off again. And they get caught in this cycle of intense, painful emotions. So that's the essence of the biosocial model in DBT. And the therapy, we have skills that we teach them for what you do when you're above the dotted line. These are the crisis survival skills, how not to make it worse, what to do other than cutting, suicide attempts, violence, substance misuse. And when they're below the dotted line and their frontal lobes are functioning well, then we can teach them emotional regulation skills for bringing down the emotion quicker. We teach them interpersonal skills. Strong, intense, powerful emotions lead to difficulties in relationships, and they've had a lot of rejection in their life, they've had a lot of humiliation and criticism, and that makes interacting with others very difficult. So we have a whole set of skills for helping them with that. And the missing one on here is mindfulness, which is telling you where you are to give you an idea of what to do. So, let's have a look just for a moment at this invalidating environment. An invalidating environment is an environment in which the child grows up in an environment which isn't recognizing the child's needs. Every child has the need for care, for support, for comfort, for nurturing, for helping them grow in an environment of safety. And very, very sadly, many people don't end up in that kind of environment. So what happens in this invalidating environment? It could be the abusive environment in which their needs are being completely neglected and for the needs of the abusers, or it could be an environment in which the parents maybe have mental health problems or have financial problems and they're working all hours of the day and night and have little limited time for the children. Or it could be environments in which the parents just don't know what to do to help. Well, one consequence is the child doesn't learn to label their emotions accurately. We learn to label our emotions when the caregiver, parent or caregiver, looks at the little baby or the toddler, the baby crying, and says, "Oh, you look sad," or "You look scared," or "You look," and they start to label emotions, and the child begins to find a label, a name for what they're feeling inside, and what they're feeling in their body and what is going on. But in an environment where they're getting mixed messages, like they're terrified because they're being abused, and the perpetrator is saying, "This is love," or "You like this," the child gets very confused. Or the environment in which no one gives them any labels. And what's the problem with not being able to label your emotions? Well, then you can't seek support from others. You can't say to someone, "I'm really scared, can you help me?" Or "I'm really sad," so people know how to respond to you. So they struggle to communicate. So when I asked my clients, at that moment in time when that was going on, what emotion were you experiencing? They say, "Oh, I was feeling really bad." And I say, "Okay, bad is a state, and I don't have a solution to bad. Let's try and figure out what emotion it was, because I have solutions for every emotion." So then they say, "Oh, sorry, I was feeling really stressed." And I say, "Yeah, you've probably spoken to too many psychologists. Stressed, again, is a state. Let's tease it apart." And one of the big tasks in DBT is I teach my clients how to identify their emotions so that they can apply solutions, correct solutions, and I can help them and other people can help them. It's a fundamental life task to be able to communicate your emotional needs to others accurately. The second thing that happens is these children grow up in an environment where no one's taught them how to manage their emotions. Again, it's a role of a caregiver. The caregiver, the toddler is feeling a lot of emotion, and the caregiver soothes them and brings down the intensity. And over time, we hand that over to our children. They have to be able to soothe themselves when they go to school. These are fundamental life tasks. Now, what we know is that small children with strong emotions who don't know how to calm those emotions down go off to school at the age of 4 or 5. And we know from the literature on how children behave is that other children, if you're very emotional, will back away from that child. They will exclude them from games. They won't want to play with them. And they, because often that child, they start to call them names, crybaby, or they get scared of them because this person lashes out, this child lashes out. So then this child loses one of the fundamental aspects of schooling. The primary school years are a time when you learn to make and break and repair relationships. That's what they do in school. I remember my daughters coming home and one of them saying, "Mommy, Mary's my best friend. Can she come over?" Of course she can. 2 days later, "I hate Mary. I don't want her to be my friend anymore." I'm like, "Okay, fine. We'll uninvite her." 3 days later, "I like Mary again." And what my daughter was learning was, she was reacting in the way that you would expect a 5, 6, 7-year-old to react, but she was learning how to repair, to forgive, and so on. So, and that's vital during that period of time, but that is missing in these highly emotional children who haven't learned how to soothe their emotions. And so when they get to adolescence and adulthood, they have real difficulties of how to repair relationships we all do things that damage or harm relationships, how to repair them. When a relationship ends, how to make new relationships. and they end up with multiple problems, clinging to problematic, destructive, painful relationships because they don't know how to make new ones, so better have one than none, or not making friends at all, being very socially isolated, and doubting their ability. So the other aspect is that these children growing up to become adolescents and adults look around and see everybody else managing their emotions and managing their problems, and they're still very emotional. So they spend a lot of time above that dotted line, just being a bit confused. And they look around and everybody else can do it. And they begin to develop a belief about themselves. I'm incompetent, I'm useless, and other people are flying through life just fine. So there's a lot of social comparison, which we know is one of the predictors of suicide. The other main predictor is social isolation. And again, they're very socially isolated. They have views that they can't do anything, and that leads to that helpless, hopeless state, which makes people very suicidal. The other thing they do is they start to self-invalidate. They blame themselves for everything. It's all my fault. I'm useless, I'm unlovable, I'm stupid, I'm so on, which fuels a lot more emotion. All of those thoughts send the amygdala off again and just keep sending them back up above that dotted line. So the goal in DBT is to regulate emotion. So one of the things I want to address right up front is there's lots of chit-chat out on social media, there's lots of documents, there's lots of campaigning and so on. I'm not here to defend or not defend the classification personality disorder. That would be a whole nother talk that Niall could give me the title to. It exists at the moment. It's in the classification systems, it's in the NICE guidelines, it's in the Department of Health requirements at this moment in time. But one of the things people say is, they come into treatment and they say, I need to deal with my trauma. I need to deal with, I was abused, I've been raped, I've had all these terrible things happen. And I say, absolutely, I'm totally here for you. DBT is a trauma-informed treatment. But I say, we've got to get you safe before we can do the work. The work won't, the trauma work is not effective if you haven't learned to manage your emotions. And it's not safe. Trauma work hurts. It hurts more than you've ever hurt before, if it's going to be effective. And you've got to sit with it. You've got to learn how to sit with the pain without dying and without running away. Otherwise, it won't work. So the process in DBT is, first, we're going to get you safe. I'm going to teach you everything you need to know, and you're going to practice, and we're going to work together for you to learn how to sit with pain without killing yourself, harming yourself, running away, harming another person. So we're going to get you to safety first. And when you've got that, then we're going to work on security and support. Trauma work is all-consuming. It will fill your mind. You are going to need support. You're going to need people to do childcare at times. You're going to need people to make sure you eat, people who look after you, and people who are just there, just to hold you when the pain is really high. Once those are in place, once we've got safety and security, we will then go into the trauma work. Absolutely. So, and I say, because if I go in too early, basically I might kill you, and that's not where I'm at. I'm not here. So that's the DBT perspective on trauma. And as I put Melanie Harned's newest book on prolonged exposure, there are other trauma treatments. This is the only one that's been, prolonged exposure is the only one that's been tested in a randomized control trial, but people do use other trauma treatments when they get to that step. People remain within the DBT program. Okay, so let's have a look at the philosophical underpinnings of DBT. The first is D for dialectical. Now my clients say diabolical because I am helping them stay with pain. Dialectical theory. The essence of dialectical theory is that for every perspective, there is a thesis and an antithesis. And I don't have a coffee mug. Normally, I would have a coffee mug in my hand with a handle on it. So there's a thesis and an antithesis. And what we're aiming for is the synthesis. So this is how if I had a coffee cup, you're going to have to use your imagination now. Imagine I was holding a coffee cup. And one side, it has a handle that I can see, and the other side, it doesn't. So I would be saying to you, what's your name? Gloria. Gloria. So you don't have to do anything. I'm just want to talk to a person then. So I'd be saying, Gloria, no one in this room has seen this object. So let's describe what we can see. And Gloria would say, it's smooth, it's curved, it's shiny. And I'd say, well, Gloria, it is, but why aren't you describing the thing you can put your fingers through? And Gloria would say, well, there isn't one, Janet. Well, Gloria, you should get your eyes checked. I'm not sure your glasses are working. And Gloria said, they're just fine. I say, well, Gloria, lying in therapy is really not helpful. And she starts to get offended. Gloria says, I'm not lying to you. You're the one, you're hallucinating. You need to go get antipsychotics. You're hallucinating. I'm like, no, I'm not. She said, well, you're the one lying. And we're off in an argument because what Gloria can see on her side of the coffee cup is not what I can see. So I say, wait a minute, Gloria, let's stop arguing. I'm going to come over and look at your side. Gloria, you're right. The truth of this object is that one side doesn't have a handle and the other side does. So then I say to Gloria, here's what we're going to do. We're going to turn it so the handle's here. And we can both see that one side has a handle and one doesn't. But of course, at that moment, I say, see, Gloria, it's on the right. And Gloria says, no, it's on the left. And we're off on another argument. That is the essence of dialectics, is that every situation we see from our perspective, from where we're standing, from our life experiences, our ways of making sense of the world, that there is no one way. The most common tug of war or dialectic that I get stuck in with my clients is, I say, you need to stop self-harming because it's a predictor of completed suicide. Self-harm is a step towards you dying. And the client says, no, 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 Janet, you've got it totally wrong. When I self-harm, I feel better, and it stops me feeling suicidal. Well, we're both correct. Both perspectives are correct. And we need to find a synthesis, a way forward. And I say, well, the synthesis is we need to get your intense, painful emotions down so you stop wanting to self-harm. So the biggest dialectic that we emphasize in DBT is acceptance and change. You are the product of all your experiences. Because my clients come in having been endlessly rejected and criticized by the world. You know, you're manipulative, you're problematic, you're a drama queen, you're useless, and so on. And they have taken on that self-invalidation. And I say, and so the acceptance side is, you are where you are. You couldn't be anywhere other than where you are. Terrible, awful things have happened. And you've done things in reaction to that you now wish you hadn't done. But that's happened. The past is history. What we want to do is influence the future. So it is as it is, and we have a skill called radical acceptance that I'll come back to. And we push for change. I can't leave my clients in desperate pain, wanting to die. Of course not. I want to help them move away from that. So I need to emphasize change. But if you just emphasize change, what clients do is react and say, you don't get how bad it is. If I could have done that, I would have already done it. You know, you don't understand, you can't make sense of me. So we constantly move in DBT between makes perfect sense. Anyone in your situation would have done that. And what can we do different in the next moment in time? Given what you know and what you've practiced and so on, makes sense why you did that. And now what can we do? And we move back and forth between these. And when I talk about the skills, you'll see that balance between acceptance and change. Then the other philosophical stance is the acceptance side, the Zen side. Now, my clients say, I'm not going to convert to Buddhism. And I say, absolutely not. Zen is a philosophy that underpins Zen Buddhism, but it underpins many other things, some of which many of you will recognize. It underpins mindfulness, living in this present moment, and validation, which I'm going to cover, and radical acceptance. So we're balancing. Dialectical theory is pushing a bit more on the change side. Zen is on the acceptance side. So let's look at these. Let's start with dialectic. I've already mentioned my coffee cup, and we're looking for synthesis. We're trying to find somewhere between their position and mine. Therapy is useless if it's just a tug of war. Interconnectedness. Dialectical theory tells us we're all connected. Everything I do affects another person, even if I've never met them. That, we have climate change. And I can be doing everything. I can drive my electric car, and I can recycle and turn my heating down and stop eating meat and do everything I can for my contribution to climate change. And there are people somewhere else in the world who aren't doing that. And their actions out somewhere else are affecting our climate here. We're all interconnected. Now, my clients have two kinds of problems with interconnectedness. They either don't actually pause and think about the impact of what they're saying and doing on others, because why would they? They're in pain. I'm up here prancing around in front of you in my high heels, right? If I fell off my heel and snapped my ankle, and I'm writhing in pain down here, and you say to me, could you stand up and finish the lecture we all got here? Well, your needs are no longer important to me. Your needs, your responses, and so on. If I'm writhing in pain down here, all I'm caring about is my needs. And I am going to get those, screaming for an ambulance or whatever. And our clients get accused of being selfish, of being thoughtless, because they're in pain and they are thinking about themselves. Why wouldn't they? And we need to recognize that and help systems around them recognize it. In our program, we do lots of family work and friend work. We've got workshops, we've got family connections, we've got all kinds of programs for them. But recognizing that our actions influence others and others influence us. My clients are quick to assume it's all about them, it's their fault. It's my fault because they've been blamed across a lifetime. And I say, well, wait a minute, that person did that. And that set off that set of events that led to that. It's a dialectic. Some aspects of what happened in that situation are down to you, and some aspects are down to them. And it's the transaction between the two. So we do a lot of work on reducing that self-blame by recognizing that any event that goes on, any argument, any incident, is a transaction between both sides. Now, I say there's only one truth in the world. Everything else is a matter of perspective. The only truth is that everything changes. The only other truth is that time only goes forward. So everything changes. My clients say, it'll never be different. It'll always be like this. That's that hopeless position, which is a marker of suicide. I say, well, I can guarantee one thing. It will not stay the same. Now, in the last 30 seconds that I've been talking, you've all had a thought you've never had before of some type. Cells in your body have died and new ones have been born. The sun has moved, some infinitesimal small distance in the sky. Things have already changed since I started that sentence. And I guarantee that that will continue to happen. What we're going to work on is how you can have more influence on the direction of change or the probability of change or the way things change. But it will happen. And we can try and stop it getting worse, or we can work towards influencing the probability or possibility that it will be better. So rather than letting change happen. So we emphasize this constantly. We're balancing that acceptance and change. We're constantly searching for what's left out. My client goes, I can't, I don't, I say, you know what? In my therapy, I do not allow the words, I can't. That is not true. What is true is either you don't know how to do this, I'll teach you. You don't want to, we'll work on motivation. Or it's really difficult and right now I don't want to deal with that difficulty. Again, we'll work on some motivation. But we're just constantly searching for what can be done. I also acknowledge that I influence them. And in therapy, this is a big part of DBT, is the recognition it's a transactional relationship between me and my client. We'll come back to that. The other thing about dialectics is sometimes it can help to unsettle. So the client says to me, I go through 3 weeks of what we call pre-treatment. You wouldn't buy a car you hadn't sat behind the wheel of and tried it out, or you probably wouldn't. Probably wouldn't buy a house you hadn't walked through before you buy it. Well, why should a client take on a year's therapy if they haven't test-driven it? So we have a test drive phase called the pre-treatment phase, or the commitment phase. And I'm a really good salesperson. I will sell the therapy like you wouldn't believe. And I will use all my Rogerian humanistic skills to make them want to see me and be with me and believe in my ability to help them. And I'm going to tell them why this is the best thing ever and sell it to them. So my client goes, okay, I want DBT. The moment they do that, they're both on one end of the dialectic. I want them to take it, and they've said yes. I'm going to jump to the other end of the dialectic. I'm going to go to the other side of the coffee cup. Oh, hang on a sec. This is a really, really challenging therapy. It involves lots and lots of practice between sessions. It involves actually going into pain in order to get out of it. The metaphor I use is you're in a burning building, and the only way out is a doorway that is filled with flames. The only way out is through those flames. The other metaphor I use is you're burning in the fires of hell, and the only way out is up a metal ladder. When you go to put your hands on it to start climbing, it's going to sear your hands. But that is the only way out. So this is really painful therapy. And it's a huge commitment. You've got to come to group 2.5 hours a week. You've got to come to one-to-one. You've got to practice every single day. And you've got to sit with pain. Are you sure you want this? I thought you were thinking about applying for university. It's going to make that difficult. Or you've got young kids, or, and this, that, and the other. So I'm going to move to the other end of the dialectic. And then my client goes, you're right. It's too much. I can't do it. And I will immediately move then over here and go, oh, no. I'm going to be right at your side. We've got phone coaching. I'm going to support you. We'll take it at your pace. I'll teach you right away how to manage pain. First thing we'll learn. I'm going to go back and forth and back and forth. The other aspect of dialectics I might be using is extending. So a client rang me up one week and said, I can't come to group, I'm too tired. And she'd been DNAing quite a lot from coming to skills training group. So I said, oh, you sound exhausted. Oh, I agree. You need a month in bed. So I'm going to put you on a therapeutic break and we'll see you in a month. Now, who's going to buy your groceries? And she said, well, what do you mean? I said, well, you need to stay in bed for a whole month. So somebody's got to bring groceries and cook for you. And she said, well, I'll order online and maybe my mum can come around and cook. Oh, great. Who's going to empty your bedpan? And she said, what? I said, you're staying in bed for a whole month because you're exhausted. And she said, all right, I'll be there in an hour. No. I knew her well. No. Now, so we've talked about this. This is just a moment for you to have a little bit of humor. So, then the other side, that's very much on the change side, the mindfulness side. I am actually not going to teach you mindfulness right now because there's no way I'll get through the whole of DBT. And many of you know a bit about mindfulness. The biggest thing my clients say is, oh, I did that mindfulness thing. Yeah, I learned it in school, or I learned it in my other therapy, or I went to this mindfulness class. It's a total waste of time. And I say, actually, what you were taught was meditation. Mindfulness is purely an attitude of relationship to your thoughts. The ability to say, my thoughts are just my thoughts. So let's try this for a moment. I just want you all to think to yourself 3 times, I am a green alien. I'm a green alien. I am a green alien. Now I'm hoping, or guessing, that none of you actually think you're a green alien. If you do, talk to Niall. But now think to yourself something that you already think about yourself. I'm fat, I'm stupid, I'm useless, I'm not a good friend. As soon as we think something like that, we believe it, because we've thought it many times. But just because you think something doesn't make it true. It might be. I'm not saying it isn't true, but thinking something doesn't mean it's true. And in mindfulness, that's what we're aiming for. When you hear, you'll see this in acceptance commitment therapy. We'll see it in compassion focused therapy. All third wave CBT therapies incorporate this idea that a thought is just a thought. And we can do something with it. I can go, okay, where's the kernel of truth? What do I need to change? Yeah, well, I am a bit, this. I'm unfit. I need to get fitter. I'll make a plan for that. Or that's just a thought. I'm not useless, and turn it to. Now, you'll notice in DBT, we always turn it to a behavior. So I always have the thought, I'm totally disorganized, which I am. If you saw my desk in my office, if we were doing this on Zoom and you saw my garden office, you'd go, oh my God, how does she ever even, get herself dressed in the morning? And I can just sit there and go, I'm so disorganized. I'm so useless, I'm so disorganized. Or I can go, okay, there's a whole lot of bits of paper on my desk with 10,000 to-dos. How am I going to put them in some sort of order where I can just, get rid of the paper on my desk, make a list, prioritize, and start working on something? One or the other. So in DBT, oops, I meant to have my pointer. The what skills are we can observe, we can describe, or we can participate. We're aiming for participate. I say to my clients, I'm not going to teach you to stop and meditate or do any of that. I'm going to teach you to live your life mindfully. Mindfully is the ability to put your attention where you want it. So think about it for a moment. How many of you, the most pain in your life is things that have happened? People who've died, relationships have ended, jobs you've lost, exams you've failed, traumas you've had. For some of you, that's the most pain in your life, and your mind keeps running to visit those past experiences. Now, for others of you, the most pain in your life is the future. What if, this might happen, that might happen, what would I do if, and so on. And you're just constantly running to the pain in the future, predicting catastrophes, predicting pain and difficulties and challenges and lost relationships. And your mind just keeps going there. Now, for how many of you is the most pain in your life right here, right now, in Greenwich University Lecture Theatre at 10-something in the morning on a Sunday? If you are in the most pain you've ever experienced in your life right now, I recommend you not be here. You should be getting some help. If this is their most painful moment, this isn't a priority, you can watch it on YouTube. And if we can, and chances are, nobody's got up to leave, you're not in the most pain in your life right now. You're not holding the hand of someone dying. You're not trying to escape a car crash. You're not being raped. You're not being told you didn't get the job you wanted. This is not the most painful moment in your life. So if we can learn to live in this present moment more, then pain will reduce. I'm not saying we don't visit the past. We're going to do the trauma work. We're going to revisit the past. I'm not saying that minds don't naturally worry. Worry has a function. It's quite helpful. It gets us to buy insurance. It gets us to... I was worried about the ice on the roads because it thawed a little yesterday and then iced over. I left 2 hours early to get here. I thought, just in case I have to drive at 10 miles an hour and slide off the road. Worry had its function. It got me here on time. But... So I'm not saying we won't worry, we'll look at excessive worry, but we're going to live more in this present moment. And and that helps you get on with life tasks. Friendships are better if you're actually listening to the person rather than thinking, oh, you think I'm boring, don't you? You don't like me. Oh, you were cross with me last week. If I'm listening to that voice, there will be that critical voice. Those thoughts are going to be appearing in the back of my mind. And what I want to do is pull my focus of attention to the conversation at hand. The second is non-judgmental. Things in the world are neither good nor bad. We like things or we don't like them. They hurt us or not. Now, judging is fine. So I go to the supermarket to buy avocados. And I pick 2 of them up and I squeeze them. And one is soft. And I go, oh, it's soft and squishy. And the other one is hard. And I go, oh, that's hard. Well, you can tell by my tone of voice that I'm having judgments. This one's bad or that one's bad. Well, no. One avocado is soft and one avocado is hard. Statement of fact. What do I want to do with my avocado? I want to make guacamole? I'll pick the soft one. I want to make an avocado and bacon sandwich? I'll pick the hard one. The avocado is neither good nor bad. It just is as it is, and I pick what I prefer. So we're helping people let go of things are good or bad. So Gloria might, I'll use Gloria because I know her name. Gloria might, come up to me in the break and say something, and I go, oh, she's rude. And it might be, and I just have to say, oh, well, that's Gloria's point of view. Maybe she might challenge me on the therapy or something. That's fine. People have different points of view, they have different values, they have different experiences, and I need to interact with people as that's their point of view, what do I choose? So, I'll be politically incorrect for a moment. So you've heard my accent, I'm an American. When Trump was voted president, I thought, I'm handing in my passport, that's it. I'm not going to be an American ever again, because the majority of Americans voted for Trump. Was I having thoughts they're bad? Yeah. And then I had to stop and say, hang on a sec. They have the right to their political opinion. They have a reason why they voted that way, and they've exercised their democratic right. Who am I to tell them they're wrong? Do I want to be friends with them? No. Do I agree with them? No. Am I going to campaign for somebody else? Yeah. But they are not bad people. They just have people who have a different political point of view than I do. So, and then being effective, doing what's needed. Sometimes, you really want to speak out, you really want to do something, and you think, hang on, this may not be the right moment in time. So, validation is an extremely important part of DBT. And most of you will recognize a lot of it. Validation is the oil that gets the wheels of change moving, in that the client needs to feel heard and understood before they're willing to change. We all are. If you want me to change my opinion, I need you to acknowledge where I'm at before I can change. Now, what we know in the DBT for substance misuse, in the randomized control trial, they compared DBT for substance misuse to what they called comprehensive validation treatment. The clients who got validated the whole way through actually stayed in treatment and were drug and alcohol free for the time in the treatment. As soon as the treatment ended, they all relapsed. Whereas in DBT, they did have a 50% dropout rate. They did have people struggling, but the ones who made it through the program remained abstinent afterwards. That's that importance of that validation and change. They were testing one of the mechanisms. Both validation and change are needed to effect change. So, what does it do? Well, it strengthens their progress in that being able to say, I get how difficult this is really hard, it makes sense why. Helps them find that self-validation, and that balance and change as feedback, my validation, and to strengthen the therapeutic relationship. My clients arrive in treatment starved of validation. No one understands them. People are all critical and hostile and difficult in their worlds because it is difficult to love someone who's repeatedly suicidal. We know in suicide, the first time someone tries it, everyone swoops in with warmth and comfort and soothing and, oh my God, I didn't realize how bad your life was. Let's sort it out. But the 5th time you've attempted suicide, the 10th time, people start backing off. People go, oh, you just keep saying it, I can't, this is too much. It's hard to love someone who might die while you love them by their own hand. And same with self-harming, substance misuse. Initially, people are very understanding and supportive, and then they back off. Remember, I'm not seeing people who have just had one suicide attempt in a period of, major depressive disorder or something. These are people who basically are trying to end their life repeatedly. For good reason, they're in intense pain. So, there are two types of validation. I'm not going to make Gloria get up and stand up in front of me, but imagine Gloria was standing next to me. So, and I stepped on her foot with these high heels. For those who can't see it, I've got very sharp heels on. So I step on her foot, and I could just keep standing there going, "Oh, Gloria, I'm standing on your foot and you're in intense pain. Oh, you poor thing." Anybody who had, my heel dug into their foot would be in pain. Well, that's not going to help her. What I need to go is, "Oh, Gloria, I'm stepping on your foot. I'm so sorry, let me remove my heel. I'll remove the source of pain." So the second one is the implicit functional. I get how bad it is, so I'm going to help you out. I'm going to get you out of there. The first is the explicit verbal. Now, I'm not going to go through the first three in particular detail, but these are Rogerian humanistic counseling skills. These are staying awake, which is, that's not just falling asleep, though one of my colleagues actually acknowledged that one time he got off a plane, went straight in from Seattle, came back to the UK, went straight to Southampton, went into a session with a client and fell fast asleep. The client left a Post-it on his forehead saying, "Dear Professor Lynch, next time could you use your sleep skills?" It's staying awake is watching. I teach my therapists not to write notes. If you're going to write notes, learn how to write notes without looking down. I want to be looking at your face. I want to be reading what's going on in your eyes, what's crossing your face. Emotions will flicker across the face very quickly. I want to see what's going on, how you're reacting to what I'm saying. If it's not working, I'm going to shift. My therapist will tell you that if you're not exhausted at the end of an hour's DBT, you probably haven't delivered it effectively, because you are totally there with the client, watching all those micro movements, vocal responses, the tone of voice, body posture, etc. And accurate reflection. This is not parroting the client. So I was watching a tape of an adolescent with a not very good DBT therapist in a research trial. And the adolescent was telling the story about picking up a chair and throwing it at his maths teacher's head. And the therapist, whatever the adolescent said, the therapist just repeated it. "So you picked up a chair and threw it at your maths teacher?" And the adolescent said, "Yes, I just said that." "And you were really angry about, the score you got on your exam?" "Yes, I just said that." And I'm writing in my supervision notes, level 2 validation is not parroting the client, just as this young adolescent, I love adolescents, they're wonderful to work with, crossed his arms and turned and looked at her and said, "If I wanted an effing parrot, I'd go to a pet shop." So when we're accurately reflecting, we're taking in what they said, digesting it a little bit, like a mother bird does. They chew the worm a little bit before they feed it to the babies, showing that you're really listening, that it didn't just go in one ear and out the other, that it went in, you thought about it, you thought about the formulation, and then you produced something you're checking what you got, but you're checking it in a slightly digested form. Articulating the unverbalized. The client who's talking to me that then curls up. And I say, "Your head's just dropped and your cheeks have just got a bit red. I'm wondering if shame has just arrived." Or your hands are clenching up. I'm wondering if you're beginning to maybe get a bit angry or frustrated, or maybe a bit of willfulness. I don't want to do that. Our hands curl up when we don't want to do something. Is that going through your mind right now? So you can't do that if you're not looking him in the face. If you're looking at your piece of paper writing notes, you're not seeing those micro movements, those resistance, them feeling misunderstood or confusion or anything. So those are all good Rogerian skills. Those three, you recognize them. Where DBT we've got these 3 levels. Now, we try not to use this one validation in terms of learning or biological dysfunction unless we can't think of anything else. Which is to say, anyone who'd had, been abused the way you have would do that. Or anyone who'd been, failed that, would multiple times at that would be thinking what you're thinking. That's actually very invalidating. I'm going to give you an example in a moment. What we want is 2 or 3 at least, if not continual, validation in terms of present context or normative function. So let me give you an example of that actually comes from a television program. Some of you've seen the drama series Grey's Anatomy. Bunch of surgeons in Seattle. Anyway, there was one series where the orthopedic surgeon is 7 months pregnant in a terrible car crash, nearly dies, the baby's nearly died, the baby's born premature, and they're in hospital for about 4 or 5 months. And the day comes when they're due to leave the hospital. And her surgeon friends are all outside, the car's been repaired, it's right there. And she comes through the revolving doors with the baby. She takes one look at the car and says, I don't think we feel right. We're going back inside for more tests. And the plastic surgeon says to her, no. You're just having PTSD because the last time you were in that car, you nearly died and your baby nearly died. And she said, you're right. I have PTSD. I'm going back into the psychiatric ward for treatment. And then Bailey, the no-nonsense kind of general surgeon, comes over and said, no, hang on a sec. You are just feeling the way every new parent feels when they leave hospital with their baby for the first time, and it has just occurred to you that you are now solely responsible for the health and welfare of this baby for the rest of your life. Welcome to motherhood. And she gets in the car and drives off. And that is true. One of my clients, I'm not going to go through the whole story because I want to get through the other type, but she came in one Monday morning. Her child was in foster care, but she had access to him every weekend because he was 13. She came in on a Monday morning, curled up in shame, and I said, something's happened. What happened? And nice and matter of fact, and she said, I threw my son down the stairs and broke his arm. The story unfolded that he'd been pestering her to buy him some Converses for his birthday, and she didn't have the money. And he was getting really rude. He was saying, well, you've been spending it on drugs. She'd been clear for a year. You just don't love me. She adores him. And he was going on and on like this. And then he suggested that if she took off her clothes, he'd take a photo and send it to all his friends to give to their dads who could come around and pay her for sex in order to get these Converses. And at that point, she was overwhelmed with fury and shame because she had been a prostitute in the past. So she goes to go up the stairs to get away from him. He follows her and grabs the back of her jeans. She pulled away from him, went to get into her bedroom, and he put his hand on the door to stop her closing the bedroom door. And she turned and pushed him so that she could get into her room alone. She knew she needed to get away from him. And he fell backwards down the stairs. And I listened to the story and I said, I don't think there's any parent on the planet that would have been desperate to get away from their child at that moment in time after an hour of that. It had been going on for an hour. Now, did we have problems to solve? Yes. Like not pushing someone when they're standing at the top of a staircase, like cutting this off earlier, like repairing the relationship, both with him and with the foster parents and with the social worker. Turns out that those weren't the issue because he told the same story she did, that it was his fault, according to him. But that's that validating. Who wouldn't have felt desperate to get away? So you've got to find the thing that was validating. And then radical genuineness is very much part of a DBT, which is I'm going to share my reactions to things, my emotions, and so on, if it will help the client. And that does strengthen. So I remember having to say to someone, are you aware that your tone of voice sounds to other people as if you are infinitely superior to them? And that was so hard to say, so hard. But she needed it, and it really helped. I said, so let's practice tone of voice. Let's tape how you say things. Let's listen to it. Let's figure out how you can change that tone of voice, because it is off-putting. It does make other people back away. So then there's radical acceptance. This is the hardest skill of all for my clients to learn. Pain is pain. I can't undo the fact you were abused or raped or attacked or criticized or humiliated or bullied. I can't undo any of those things. Pain is pain, and it's yours for the rest of your life. I can't take away those events. I can't wipe your memory. I can't undo history. History happened, and it was painful. And I have a really, really difficult piece of news for you all to hear. Pain happens in life no matter what you do. Every one of you will feel pain in the future. Pain happens. People will die. People will get in accidents. People won't like you. You will lose it. You will, not get a job you apply for. You will not get something. You will be disappointed. Think pain is the way life is. That's one of the Zen philosophies, is that pain is part of life. And Peter Fonagy talks a lot about that. He thinks that the biggest problem in personality disorder is a missing resilience, the ability to experience pain and move on from it. Not necessarily instantly, but move on from it. The ability to seek support when you're in pain, the ability to problem solve, the ability to tolerate it and go, yeah, this hurts. Okay, now what do I do? Yeah? So pain is a part of your past life, and pain will be part of your future life. I think one of the most difficult things done to our society was when we put out these happiness tests. Let's find out how happy the nation is. Well, that message suggests that we're meant to be happy all the time, or more often. Well, yeah, I'm going to help you, if you were my client, to experience happiness more often, definitely. But actually, we've got to get the mindset. Life is, at best, mundane and a bit boring. Every time I'm doing the washing up or yet another load of laundry, yeah? It is. Most of life is a bit mundane and boring, punctuated by pain and sadness and problems, and punctuated by happiness. And that's what we're going to be aiming for. Now, what is the problem for the individuals I work with? Is they've got pain, and boy, do they have more pain than the rest of us. Definitely. They have had more terrible and painful experiences. But then they don't accept pain. The suffering is, it shouldn't have happened. It ought not to have happened. It's not fair. I said, well, you're right. I wish we lived in a world in which no child was abused. I will continue for the rest of my career and life to figure out, if we can figure out how to reduce the probability of a child being abused. Absolutely, we can work on that. I don't know the solution, but we can chip away at it. Better parenting, better monitoring, I don't know. But, no amount of saying it shouldn't have happened, it ought not to have happened, is going to undo it. What you're adding is suffering. You're adding frustration and anger. You're adding all kinds of other emotions that come on top of it. And your mind is filled with, it shouldn't have, it ought not to have that. If somehow that's going to change the story. The story is as it is. Let's co-create the next story. Where do you go from here? And if you enjoy reading books, I recommend a book by a man called Henry Fraser. Henry Fraser was, when he was 17, I think, he dove into the book is called The Little Big Things, A Story of Acceptance and Making Every Day a Good Day by Henry Fraser. And he was 17, he had everything going. He was super bright, A-levels, doing his A-levels, he had friends, he was going to try out for Saracens Juniors, he was a great rugby player. He and his friends went on holiday and he jumped into a pool of water that was more shallow than he thought, and he snapped his neck. And they flew him back to Stoke Mandeville from holiday, and he's never been able to move a muscle from his neck down. Initially, when he was able to talk, he said to the nurses and the doctors, to his friends, to his parents, his brothers, he said, just kill me. My life is over. Everything I ever thought my life was about is now over. And of course, they all said, well, we're not going to. And his story, he talks about is how he was able to turn his mind to, this is awful, everything I ever wanted, everything I ever knew is done, to, okay, I don't like this, I'm not happy about it, I wish it hadn't happened, but this is the life I've got now, what can I make of it? And what he's become is a very famous painter. He paints with his mouth and lips, paint brushes. His paintings are in the Tate Modern. He paints T-shirts and sweatshirts for the Teenage Cancer Trust. He writes inspirational books and he gives inspirational talks on how to get on with your life when the worst that you can imagine happens. And my clients, a lot of them buy the book, and the quotes help them out. But it's about saying, yeah. And he says in the book, every day I wish my life wasn't like this. Nobody would wish for that life. But it is as it is, so what do I do now? And helping your clients come to that position. The other one is this suffering about suffering. I can't stop thinking about the past. I can't keep revisiting it. And I keep predicting that it's going to happen again. Because it happened in the past, it's going to happen again. And you get so caught up in being in the past and the future, and in the judgments and in the pain, that you are unable to focus on, okay, what do I do now? And focus on this present moment. And that's suffering about suffering. What we say in DBT is, it isn't fair that it happened to you, and it did happen. And you didn't cause your problems. You didn't cause them. The perpetrator did. But you're the only one who can solve them. Who else can solve your problems? So to solve a problem, you have to accept the problem. I'm just going to very quickly go on to one more bit. In DBT, we use a lot of self-disclosure. But I'm not going to sit there and go, oh, this week let's talk about me. No, that's not what we're there for. I want my clients to believe in the therapy. I want them to do the hard work, and it is hard work. Learning DBT and changing your life is really hard work. But they've got to believe in it. Well, I can spout all the randomized control trials. There's 54 randomized control trials. There's no doubt the DBT works. It's got a massive evidence base and practice-based evidence as well. So, yeah, and that won't make any difference to them. What I need to say to them is, I use DBT. I think it's unethical to suggest things to people that I wouldn't do myself. So I go in there and I say, when I had this experience, I used this skill. Or, oh yeah, when they tell me why some skill didn't work, I say, yeah, I remember one time I tried to use it and this went wrong. So I did some thinking about it and I talked to people and then I tried it this way and it worked. I don't offer up to my clients anything that I haven't tried out and I don't use in my daily life. And actually, one of my clients said, you know what? In my previous therapy, my therapist said practically nothing. And what I felt like was telling them all about what was going on. I felt like I was standing naked in front of them and they were fully dressed. And it was just humiliating and shaming. She said, I feel like you and I are sitting together in a room in our bikinis. And I said, yeah. No. Now, there are plenty of things I won't share with them. But there's a lot to be said for considering if it's in their interests. I will share my hopes and beliefs for them. I will give them examples of when I used the skills. I got to tell you, I got 100% attendance at my skills group. When I came in, my ex-husband came home on a Friday night, 23 years into our marriage, and said, been having an affair, I'm going to marry the other woman. And I went and told my clients on the Wednesday about what skills. And I said to them, you guys coach me, what skills do I need? I got 100% attendance for about 3 months as I shared the use of skills to get through this. So, pulling this together and moving on to what a DBT program looks like. DBT is a behavioral therapy, but we believe that cognitions are behaviors. That cognition occurs, it can either be a stimulus and we have a response to the cognition, or it can be a response. But we treat cognitions, and we do. A lot of people think, oh, DBT therapists don't deal with cognitions. DBT is a third wave CBT therapy. We deal with cognitions, behaviors, emotions, relationships, context. We deal with it all, the whole gamut. So, but it is a skills deficit model. We believe that in their invalidating childhood environments, they didn't learn the skills to tolerate distress, to soothe themselves, to regulate emotions, to manage their mind and their cognitions. And so we will teach them skills. And we will do chain and solution analyses, which is, okay, so at 11 o'clock Sunday night, you cut yourself with a razor blade, you were in the bathroom, and so on. Okay, who else was in the house? Oh, your mum was down the corridor. Okay, so let's just rewind the video by 2 or 3 minutes. Just before you went to get the blade, what were you thinking? What was going on in your body? What was going through your mind? What emotions were you experiencing? What urges were you having? And we rewind the video, just no more than about 10 minutes. Now, there might be an event. Oh, well, I had an argument with my best friend over social media an hour before. I said, okay, well, we'll tackle that later on. Right now, we have to figure out how it is you have an argument with somebody, experience all these emotions, and what can you do differently other than going and cutting? So we will tackle the friendship. So we do a behavior and then we weave solutions in, and they're always acceptance and change. So you might have a problematic thought. She's a horrible cow. Okay, and she hates me and she's going to tell everybody and I won't have any friends ever again. That's a typical sequence for my clients. And I say, okay, so we've got, what's more painful? Is it more painful thinking she's a horrible cow, or she's going to tell everybody and I'll have no more friends again in the future? And she said, well, it's the no more friends. That's what led me to try and to self-harm or try and kill myself. I say, okay, so let's think of an acceptance and a change thing we can do with this thought. On the acceptance side, we could notice it and let it go. We could distract from it. We can just, we can just name it. A thought is just a thought. Doesn't mean it's going to happen. Might have some, might not, but yeah. So we can do all that on the acceptance side. And on the change side, well, let's do some challenging of that thought. Let's actually notice it as a prediction. Let's do some problem solving, some cognitive modification. So I would offer them solutions on both sides, and we would practice it in the room. This bit, rehearsal and generalization, is the big part of DBT. We practice it in the room. We practice doing whatever we'd agreed. We practice the cognitive work. We practice the behavioral. We might have to do it in imagination, but we do it over, and then I give feedback, and then they do it again. Coaching. I row twice a week in an 8. So I row up and down rivers. And we've got a coach on a bike, riding as we're rowing along. And he shouts, stop, and we all stop, and he gives each of us feedback in the boat about what we could do differently. Then off we go again, and he rides along watching us, and then he shouts, stop, and said, well done, you changed your posture there, and well done, your timing's better, but now you need to do this. And we just get constant feedback on what we're doing. If you don't give people feedback, how can they learn? So the biggest part of a session in DBT is spent on rehearsing the skills that we've come up with and the generalization. And this is the list of skills. These are what you read about in the manual, and we're teaching problem solving, cognitive restructuring, self-validation, and dialectical thinking. Right, so let me summarize the DBT model for the chain analysis. What we think is happening is that a cue or a trigger, I prefer the word cue to trigger. A trigger is like a gun. Once you pull the trigger, the bullet goes, no matter what. Whereas a cue is a signal that you can or can't. So when the red light turns green, that's a signal I'm now allowed to move my car forward. Doesn't mean I will. Somebody might have shot out the other side, or there might be some reason why I don't. A cue still gives you a choice. So I know it sounds a bit just like linguistic playing, but with my clients, I tend to use the word cue to keep signaling, even when the cue occurs, you still have a choice. In DBT, we always think you have a choice. So the cue comes in, and the person gets emotionally dysregulated. Their emotions soar up above that dotted line, and they seek a solution. They can run away, or avoid, or reduce. We call that the problem behavior. So we have a fundamental language problem in therapy. Self-harm, suicide attempts, violence, substance misuse, by other people's definition, is the problem. But if you say, we're going to work in this therapy to reduce self-harm, what they hear is, I'm going to take away your means of feeling better and leave you in pain. Because self-harm is a solution for them. It's a problem for me. So we need to acknowledge that fundamental problem straight away. And I say to my clients, I want to help you stop self-harming and attempting suicide and so on, because I can't deliver therapy if you're dead. But that doesn't mean I want you in pain. I'm going to offer you alternatives to cutting, to suicide, to violence, too. So I think that's a really key part of DBT. So they do the behavior, they cut, and they will feel better. It's operantly conditioned. Remember I said when you cut, attempt suicide, violence, drugs, you drop from that pain above the dotted line down to feeling better. Every one of them reports that. If they didn't, they wouldn't do it again. And that operant conditioning is not something that's very easy to take away. I can't make self-harming not feel better and make them reduce their pain. But what we can do is get other things put into place. They feel a bit better. Then, as I said earlier, they start self-invalidating. Oh God, I'm useless, I did it again, they're gonna hate me, I said I wouldn't, I've now got more scars, etc. And off they go to emotional dysregulation. So where does DBT break in? What are all the things we do in DBT? Well, I can break the link between the cue and emotion through exposure. If every time you see a snake you feel fear, I can do a phobia treatment and you can stop feeling fear in the face of a snake. So I can do exposure, or I can do stimulus control. Let me just check the time. Yeah, so one of my clients came into skills group. She'd been badly abused in school by a teacher who happened to be a middle-aged, balding man with a goatee. She walked into her skills group for the very first time. I never asked her what the teacher looked like, so I didn't warn her. She walked into skills group, and it was being facilitated by one of our therapists, who's a middle-aged, balding man with a goatee. She screamed her head off and ran out. So we calmed her down, and we said, okay, this is an opportunity, because this man has never harmed you. He looks just like the man. It makes perfect sense. Why wouldn't you run screaming out of the room if you saw someone that looks just like your abuser? However, the world is filled with middle-aged, balding men with goatees. So we're going to use this as an opportunity, but what we did was stimulus control. We got her to sit in a part of the room where she could hear him and so on, but couldn't see him initially. And then gradually, week by week, we got her to the point where she could see him out of the corner of her eye, and then gradually to the point where she could sit across the table from him. And she worked her way all the way up to sitting next to him in the skills group, which took a while. It took about 4 months, but she did it. So we can control the stimulus. We will be teaching people how to change their emotion and how to reduce emotional vulnerability. I'll show you that if I get that far, how we can get the baseline down so it takes longer to get to that dotted line. We will teach people using distress tolerance, distract, avoid, or accept, to experience the pain without doing the problem behavior. We can teach opposite action to the problem behavior itself. Instead of picking up a blade and cutting yourself, you're going to pick up hand lotion and rub it into the skin. That's the complete opposite of cutting your skin, is rubbing hand lotion into it. That's a difficult one for them to do. Opposite action also is part of changing emotion over here. They're two different things. Sometimes we can block the relief. If a client, I've got numerous clients who their partner goes off to the pub and is late, and they message their partner saying, if you don't come home, I'm miserable, it's awful, if you don't come home, I'm going to kill myself. Partner comes fleeing home. So we can work with the partner saying that's probably not the most helpful response, though that is difficult to get people to not do. We can do some contingency management, and we can do self-validation and radical acceptance about, once you've done it, we can learn from it and so on, but stop beating yourself up about it. So those are all the different places we can break in, and those who know CBT are thinking, yep, sounds a lot like CBT as well, which it is. Okay. So I'm going to teach you 5 ways to change a problem. 5 ways to change. And I'll give you 2 examples. So, okay. Imagine, and this is a handout I give my clients. So I used to live in Epping Forest, and I had 2 beautiful border collies who needed 10, 15 miles worth of running per day. Now, imagine that I developed a fear of snakes. Okay, so I sit on my sofa and I say, right, I can't take my border collies out because there might be snakes in the forest. I know there's snakes in the forest. It's awful. And my border collies start to get unfit and unwell. They start to get irritable. And I sit there thinking, what a terrible pet owner I am. I love my dogs, but I can't take them out because there's snakes in the forest. You come along to offer me treatment. Well, you say to me, well, the first thing you could do is solve the problem by removing the cue. That's fine. I'll move to Ireland. There's no snakes in Ireland. Remember, St. Patrick banished the snakes. Move to Ireland, no snakes. Now, those of you who are Irish are saying there are, but don't tell me that. So I could solve the problem by moving somewhere with no snakes, and then it's not an issue. The next thing we could do is one of you lovely psychologists could help me do my phobia treatment. Treat me for a fear of snakes and change my emotion until I love snakes. I have pet snakes. I have them wrapped around my neck. I could tolerate the distress. I could go, okay, every time I go out, I'm going to be anxious. I'm going to wear tall wellies and tie ropes around the top so snakes can't get up and into my wellies, carry a big stick. My heart's going to pound. I'm going to be slightly tearful, and I'm going to go through the forest anyway. So I can tolerate the fact that I'm anxious and just be anxious. I could stay on the sofa and be miserable. That is an option. I can just sit and look at my dogs and go, oh, what a terrible owner I am, and those poor dogs. I could make it worse. I could look up how many poisonous snakes there are in Epping Forest and what it feels like to die of snake venom. That would make it worse. Let me give you a clinical example. Client came in, long story short, she had a really problematic mother who was continually critical of her, just never ceasing critical. My client, before I saw her, she'd been working as a runner for BBC Studios, and on a 0 hours contract, she fell down a flight of stairs and broke both her legs, and was told it would be 4 to 6 months before she could walk again. They, of course, stopped her job. She didn't have enough money to pay her rent. She had to move back in with mum. And she attempted suicide 3 times in 2 weeks. So she gets put in front of me. And I was talking to her about this list. I said, well, do you want my help talking to social services about getting you housed somewhere else? And she said, nope, my mother's the only one I'll allow to help me bathe and go to the toilet. I won't let anybody else see my naked body. I was like, okay, so you're stuck with your mum for 4 to 6 months. Let's change your emotional reaction to your mother. Instead of being filled with fury and despair, fury, how dare she say these things to me, and despair, she's right. I said, let's change your reaction to your mother, because it was the fury that was leading to the suicide attempts. I said, maybe we can pity your mother for being the kind of person she is. Maybe we can see it as love, that she sees it, you see it as criticism, but maybe she sees it as love. I don't know, that's whatever other emotion we can come up with, we can change the emotion. She goes, no, she's just horrible. Okay. So I said, well, how about I teach you how to tolerate it? Let it wash over you. Ignore it. Just let it go. Just keep saying to yourself, this too shall pass. One day I'll be out of here. She said, no, it's too painful. It's too awful. She shouldn't be like that, and so on. I was like, okay. So I left her this list. Now, I didn't list the last 2. I said, here's the deal. If you want any of these first 3, then come back for therapy. I'm totally happy to help you with any of these 3. If you choose either of these, well, stay miserable, make it worse. You're already an expert. You don't need my help. So she came back the next week, and she said, well, I started by making it worse. I was like, oh, what'd you do? She said, I thought I'd fight fire with fire and be as critical of my mum as she is of me. Turns out she's better at it than I am. So I said, okay, what have you decided on? And she said, what she actually said was, can we start with tolerating it, and then I'll see whether or not I can change my view, but let's tolerate. So that's that first stage of therapy was tolerating it. She eventually began to find ways to find out more about her mother and why she was being treated by her mother the way her mother had been treated. So I think this is great because it gives clients choice. And it orients what the options are in therapy. Okay, what does a full DBT program look like? A full DBT program, what we call comprehensive DBT, which is where the evidence base sits, has in it functions and modes. Improving capabilities, they go to a DBT skills training group. I don't call it a group, I call it DBT skills training sessions. It's a classroom for learning skills. Those skills I listed earlier: mindfulness, distress tolerance, emotional regulation, interpersonal effectiveness, which is divided into two: assertiveness and making friendships, repairing friendships, keeping friendships going, and letting go of destructive relationships. Very painful skill and so important. So they come to DBT skills training, 2.5 hours a week. It's set up like a classroom. They're expected to take notes. We've got handouts, we've got whiteboards. And first half is let's review what you practiced last week. Second half is let's learn some one or two new skills. Notice I said what you practiced last week. Top tip for those of you thinking about doing some DBT. I don't call it homework. If you call it homework, people do it once. I don't know about the rest of you, but when I was in school, essay was due on Friday. Thursday night, 10 p.m. went, oh, got to write an essay, yeah? If you call it practice, you do it every day. If you're learning the piano, if you're learning to swim, learning to drive a car, you practice every day. So they practice. Now, so they go to group. Now, group has multiple functions. It's cost effective. 12 of them, 2 of us, pretty good for health economics, right? However, it's also that they learn from each other. If they and I did the skills in a room together, they only have their example and maybe one example from me or 2. If we're doing it in the group setting, they're hearing how other people used the skill in different situations. And also, as they get settled in, they begin to help each other. And one of the ways to learn is to be able to teach something to somebody else. So group, and also, of course, there's normalization. I'm not the only one in the world with these problems. So lots of reasons why skills training is done in a group setting. And they get weekly individual sessions. So they learn in the skills training sessions, a bunch of skills, and then in the individual session, we look at specific examples in their life and how to weave that in. So my colleague Christine often says, skills training sessions are like filling the pond with fish, and the individual session is let's go fishing and find a fish that will solve this problem. So we will weave them in. So they have 2.5 hours of that, an hour of that. Then they get generalization, they get phone coaching in a fully comprehensive. They need a means of getting a hold of you between the times they see you. Because what happens is, they come in, and let's say shame is the issue. They're riddled with shame, they're curled up, barely speaking. And we spend a whole hour on regulating shame and on managing shame and so on. And I am going to be pushing to get the shame back. They regulate it, it goes away, I get it back again. I always say to my therapists, if your client isn't curled up in shame or shaking with anxiety or sobbing with despair or pounding the wall or the table with their fist, it's a wasted session. You've got to bring up emotion and then teach them to regulate it. You wouldn't teach someone to swim just by talking about it. You got to put them in the pool. You wouldn't teach someone to drive from a book. You sit in the passenger seat and give them instructions and reach out if you need to grab the steering wheel. That's what we do in therapy sessions. We bring on the emotion and we help them regulate it. So now, no matter how good I am at bringing on anxiety, anger, sadness, disgust, any emotion in the room, the client leaves and the real world occurs because I'm a safety signal. They know that if I'm in the room with them, I'm not going to let anything bad happen. So I become a safety signal. So their emotion goes up, but it doesn't usually go above the dotted line or just a little bit above. They go out in the real world, I'm not the cue anymore for safety, and something happens and their emotions soar that much higher. And they're above the dotted line. They can't think straight. They can't remember what to do. So they need a means of remembering what to try. Well, they've got a list of skills. They could look at that. They've got some prompts of various sorts. Or they can ring me. They can ring me and say, I'm in this situation and I don't know what to do, and I don't want to cut, so what should I do? They cannot ring me if they've already self-harmed, attempted suicide. Don't ring me, I'm not an emergency line. I'm also not instantly available. I'm talking to you guys this morning. My phone's on silent. I won't check it until I get in my car to drive home. I'll have a quick check, see if anybody's called me. The reality is I get 2 calls or texts a week, that's it. And I've got a lot of clients on my books, a lot. I probably have 300-400 people who have access to me. I mean, I'm not treating all of those, but because I'm head of service. They could contact me. They just don't. They do when they need me. So we are available by phone, by text, and by email. And what I say is, I don't know when I'm going to get back to you. I'll try to get back to you within an hour or 2, but it could be end of the day. It might even be tomorrow. I have a life in addition to being available to you, but leave a message. So many of my clients say knowing they can leave a message helps. I would rather spend 5 to 10 minutes on a phone call giving them skills to use in the real world where they are than deal with my emotions if something happens to them, or, to be honest, to deal with the SUI paperwork. But I really firmly believe in the power of being available to them. And what they say is, even if they don't use it, knowing they could, knowing that someone out there will get back to them who cares and understands them is a big, big part of their believing in themselves. Sometimes I call back. One woman said, I'm suicidal, and someone give me a call back. I can't stand it. My husband said this. I didn't get back to her for about 5 hours. And because I was teaching during the day and so on, and I got back to her late in the afternoon. And she said, oh, while I was waiting for your call, because I knew I couldn't do anything, we agreed I wouldn't do anything between when I left the message and you called me back, I got on with the ironing and folded the laundry, and now I actually feel okay. I was like, okay, great. So you used, what's the name of that skill? It's accumulate positives and distract. So we offer that. Structuring the environment, I'm going to help the people around this individual to support them in learning. I am going to give them a supportive environment where people reinforce them for change, where people notice change, where people remind them. We have family, we teach DBT to families, we have couples work, we have families work. I talk to social workers, school teachers. I'll talk to anybody, talk to employers. I just finished a large randomized control trial of DBT for employment. I'm in there. If the people around you want to know DBT and how to help you, I'm there for you. So we will structure the environment. And then finally, we recognize that our clients influence us the way we influence them. We have emotional reactions to our clients. If every time I bring up something, the client gets angry, it's going to cause me to back off. If the client is, silent and so on, it's going to lead to thoughts of giving up on my part. I might get pulled into their despair and sadness. I have emotional reactions to my clients. And I also can be pulled off model. The client who really just wants to talk and have supportive, warm, supportive counseling, well, that's fine. That's just not the model I'm providing, so I get pulled off model. So in DBT, if you are doing DBT, you're expected to go to a weekly consultation meeting. And this meeting is not about clients. It's not, what should I do with Mary? What should I do with Joe? And so on. This is about the therapist. We say, I'm feeling anxious about my session last week with such and such. I'm feeling irritated. I'm feeling like giving up. I can't be bothered anymore with this. I don't want to say what needs to be said, whatever. Or we're not being dialectical. I'm thinking, well, they've missed 3 in a row. We might as well discharge them. They're not answering the phone. They're not getting back to me. Let's discharge and move on to the next one on the wait list. And my team will say, well, that's one option, but let's be dialectical. Let's think what the other options are before you give up on them. So consult is helping us be dialectical, helping us manage our emotions and recognize the transaction between us and our clients. That's a full program. And that's got lots of RCTs. Now there is also, some people have been reading about DBT skills program. And people call it DBT skills alone. There is no evidence base for running a DBT skills group on its own. The evidence base is for running your skills group, offering the generalization, could be phone coaching, helping to structure the environment, and going to consult. The programs that are called DBT skills alone, they often this is not all within the individual. So like structuring the environment might be a care coordinator or even a GP. Generalization might not be, I mean, the generalization would be the skills coach. So these two would be offered by the DBT therapist, and they would go to consult. The structuring the environment and checking in on risk and so on, which what we do in one-to-one, could be done by a care coordinator or another person outside the program. So what's missing is that one-to-one sessions. Now, the evidence base for doing this and removing the one-to-one sessions is for people with less complexity, so they don't have a whole bunch of different types of diagnoses, and for people less at risk. I would never offer this to somebody who was regularly suicidal. Now, I can see that I've come up to the end of what I can cover today. So what I'm going to do is I'm just going to orient you what's on the slides. That's just how you learn acquisition, strengthening, generalization, and applying. This is what we would do in the emotional regulation. I want to get to a particular thing. Now, these one's emotion chart, what you want to read is, where is it? You want to read this book if you're interested in how DBT regulates emotions by Christine Dunkley, one of the DBT trainers. Fantastic book on what you do with emotions in DBT. And this is one of the world's greatest books. Every emotion has a signature in the face, the eyes, the voice, the body. And Paul Ekman, some of you recognize him, world's most famous emotion theorist. Brilliant book if you want to understand emotions. And my clients buy that one too. I just want to get to the last slide. Right, adaptations, last slide. DBT is not just for people with personality disorder. There's an evidence base for substance misuse, for suicidal adolescents, for bulimia and binge eating disorder, for older adults, chronic resistant depression, for exiting mental health services, PTSD, my one, DBT for employment, for LD, ADHD, ASD, it's everywhere. Most recent one is bipolar. And you can learn more about these in some of these books. I want to highlight this one. Addressing race-based stress in therapy with Black clients. This is an American-based book using DBT. It actually adds some extra skills for recognizing and managing microaggressions, macroaggressions, and interactions. So, and this is the LD one. So I think I am open to questions now.
Is that working? Yeah, I think it is. So thanks so much, Jana, for a fantastic presentation. I can tell you've done that about 100 times now, so well done. The first question, we've got two questions from the people tuning in from the live stream at home, and then we're going to pass this microphone around. So if you've got a question, just raise your hand, and I'll give you the mic. So first question from Zandra Bamford. How can you teach people to change emotion or ways of surviving or coping with trauma when parts of the self continue to be stuck in trauma scenes? Isn't it just covering over the trauma in a different way without ever healing or addressing a young part that is trapped and stuck in trauma without the adult help it needed? Doesn't the temporary plaster unstick and need constant sealing over again and again?
Yeah. Well, and that's what I had hoped I had covered on the slide about how DBT manages trauma, in that we absolutely recognize there's a need to do formal trauma work. We're using whatever trauma model is appropriate. But what we believe in DBT is we need to help people be safe to do that first, and then have a network around them in order to do that work. And so it's by helping people to say, yes, all these terrible things happen to you, and it's left you here. Wherever you are is where you're at. We're going to work on where you are and get you to a place of safety in order to be able to do that work. One of my clients highlighted, what she said was, well, doing DBT was like you're out, you've decided to swim the English Channel, and you have a heart attack halfway across, and they can't do CPR in the water. They've got to get you on the boat to do the CPR. And that's what we're doing. We're going to get you on the boat. And the experience and the evidence base from DBT is the act of teaching people how to notice when their mind is doing all those things that you identified. It's going back and revisiting the trauma over and over again. It's invalidating yourself. It's having all those difficult thoughts about yourself and bits of your identity that keep the trauma identity, and noticing that and bringing yourself back to the present. And people with very severe trauma, many of my clients are dissociating regularly, they're having flashbacks, nightmares, lots of problematic thoughts, all of which trigger lots of emotion. Step one is to regulate the emotion in the face of those cues, and then step two is to reduce those cues through trauma work.
Thank you very much. Okay, the next one is from Cassandra Gazile. Cassandra asks, how does one work with a client who is scared of change because their pain or suffering is all they've ever known?
Absolutely. Being right by their side. The first step I would do is to validate and acknowledge that absolutely you are swimming in this pool of pain, and you have no idea what it would look after pain or with less pain. One thing I do is I tell my clients, I can't get rid of all the pain you've got. The pain you've got is the pain you've got, and it will probably be part of you. It won't be so intense, and you won't be focusing on it in the same way. Similar to a pain model, a physical pain. If I was doing CBT for physical pain, I'd be saying, we can't get rid of your rheumatoid arthritis, or the damage that was done to the nerves in your back, or whatever. You are going to have pain, but we can learn to live with the pain, we can learn to distract from it, we can learn to reduce it, and we can learn what we're doing that makes it worse, and try and change those. And then we will go back and tackle the pain. But you're absolutely right in that takes a whole lot of motivation, and it takes a whole lot of connecting to your therapist. You're not doing this alone. You are doing it with me. DBT puts a big emphasis on the therapeutic relationship. And it's a long-term therapy. Some people deliver it every week for a year. Some people deliver it as 46 sessions where you've got weekly, then every other week, then monthly. But I'm going to be with you for a year or two. As long as you are making progress, I'm going to stick with you. And that could even be longer. So what DBT doesn't do is keep going with people who aren't changing. But if you're participating in the change and we're seeing evidence that it's working, because if it's not working, this is the wrong model. But those who, that we will be right by your side and acknowledging that this is going to be really hard and we don't know what it's going to look like, but we can influence the future.
Thank you, Janet. Okay, so I'm going to open this up to the audience. Anybody got any questions here?
Absolutely. Thank you very much for the talk. Absolutely fascinating. But how do people access this? So when people come along, say through their GP, or they have a difficult background, how would those potential clients be assessed? And equally, are there going to be people who have no capacity to endure this particular therapy?
Right. Let me separate that as two questions. First of all, every place that DBT is offered, every organization it's offered in will have their own referral pathway. So in my trust, the referrals come to us straight from the inpatient unit, because there's a high risk and home treatment team, from psychiatric liaison, where we pick them up from A&E, from secondary care, from IAPT, or it can be from the GP. We have a rapid screening process so that no client is left waiting more than 4 weeks before we've screened to see whether or not whether to offer them DBT, but whether DBT, whether the problems they have are the kind of problems we can work with. Whether they're motivated or believe in it, that's not the issue. It's just, do you have intense emotional overwhelming, or have shut down so far that you have no emotion, which blows up periodically we take people who are self-harming, suicidal, substance misusing, violent, self-neglecting, and disengaged. That's who we take. If you've got those problems, and it looks like it's from. And what we exclude is schizophrenia and other schizoaffective disorder, because we don't have an evidence base on for DBT. Now, so the referrals just come in, and you know, in our area. In other areas, some people require it go through secondary psychology services. There'll be just different pathways. In the private sector, you just make a phone call. So now, and how do we assess? We're going to be doing that assessment in that phase I called the pre-treatment phase. So the assessment, I will meet with somebody and just find out what's going on. Then I'm going to be asking them, I will take people who can identify at least one life worth living goal. Otherwise, therapy is all negative. Stop self-harming, stop trying to kill yourself, stop taking drugs, stop hitting people, stop running away, stop, you know. No, I mean, I don't want a therapy that's negative. I mean, those are obstacles to a life worth living. So the goal in DBT is how to build a life worth living. And they go, I don't know, I've never had anything, can't imagine anything, I don't want to get disappointed. And I say, well, we're going to work on that first. What would your life look like if these problems and pain went away? Would you be in a loving relationship? Would you have kids? Would you have a job? Would you travel the world? Would you dance ballet in a ballet club? What would you be doing in a life that didn't have these problems? And I will spend quite a lot of time on that. And you notice that I'm then weaving some motivational interviewing type techniques in there. If I can get one life worth living goal out of them, often more, and it can be concrete, not, I want a wonderful relationship. Okay, what would that look like? Would that be sitting on the sofa holding hands? Would that be, you know, what would that look like? If I can get one of those, then I say, okay, and you've got these are the obstacles: self-harm, suicide, drugs. They're all obstacles to getting that. So, do you want to work on reducing those obstacles? Do you want to work on that goal with me? And that's what I'd be looking for to take them in. Does that help?
Yeah.
Hiya. So as you said, DBT is typically used for sort of high-risk individuals with suicidal behaviour, self-harm. Do you think there is a role for low-level needs, such as in an IAP service or early help, where it's sort of not at the moment?
Yes, DBT is a little bit long-term for IAPT, but a lot of IAPT services run DBT-informed groups. You can teach, I mean, all the DBT skills are good life worth living skills. And in fact, that's why we've got DBT in schools. It's already in the national curriculum. One of my staff has a 5-year-old, and he came home with a handout 3 weeks ago that had a bunch of emoji faces, and it had some simple emotion words: happy, sad, mad, you know, and they had to draw a line between the word and the face, and then they had to write, when I feel happy, it makes me want to do. And she had to help him with the writing bit, because he doesn't write yet, because he's only 5. They're already teaching emotional regulation in schools, and mindfulness. My daughters kept saying, oh, Mum, they're doing that mindfulness thing again. Do I have to go? All the DBT skills are really good quality life skills that, if in an ideal world, you would have got from your parents and maybe a bit from school at a young age. So there's nothing stopping you teaching DBT skills in a group in IAPT or any other setting, but just don't call it DBT unless you do full comprehensive. Call it DBT informed, or call it an emotional regulation group, or a mindfulness group, or assertiveness group, whatever. So that's what I would say there. Now, I talked about the high-risk populations. But actually, for example, I've run DBT for bulimia in eating disorders where they're not suicidal and self-harming. They are overeating and bulimia. So, and there's a program in Deborah Safer's book. There are the program, the race-based stress one. Many of those people aren't suicidal and self-harming, but the DBT skills give them a new way of managing the ongoing, relentless problems that come. So, yeah, you can. So you'd want to look at the different options. It's not only for high-risk people. It's just that, remember, if you wanted to plant your daffodil bulbs, you know, you wouldn't use a bulldozer. You'd use a spade, right? So full DBT is too much for some programs, and for some individuals with some problems. The full DBT is written for these very high-risk, very complex, often traumatized. Not all of them are traumatized, but many of them. Great, thank you. Niall's disappeared.
Just up here.
There's a hand here, Niall.
One up here as well.
Oh, there's one there, and then this woman here with the black jumper.
Hi there, my name's Wilson. You just have to tell me if the question I asked has been covered because I was on the train late here, and so just please let me know. I don't want to get you to repeat yourself. I guess I was going to ask what, in the last 10 years, it's been very tumultuous around BPD and kind of dialectical behavioural therapy, and I wondered what's the most effective way to challenge the stigma that's still kind of around with maybe people, even those in clinicians who kind of still don't kind of grasp it. Do you know what I mean? Because it can be quite a hot button topic, if you know what I mean.
Well, I think the stigma is around the label of personality disorder, not the therapy. It's just that DBT, most people connect DBT with personality disorder because that's where it started from. But now we have an evidence base for pretty much every population. DBT can be useful. DBT is just a therapy. So the stigma is around personality disorder. I sit on the National Personality Disorder Anti-Stigma Group with the Department of Health, NHS England, Mind, Rethink, and so on. We're working on that. We're going to be doing we're working on the same thing that they did with the Beat Depression campaign. Let's talk about depression by making everybody talk about it and finding famous people like Ruby Wax and Stephen Fry with mental health problems and get it out there. It's very much less stigmatized in the US now because they've done a big campaign. So we're working on that. We're working on, people are thinking about what do we do to get rid of the label. One of the difficulties you've got is you can get rid of the label, but the stigma remains. You may not be old enough to remember the days when DSM called people with learning disabilities mentally retarded. People used to call them spastic. So they got rid of those names. Oh, we don't call them retarded. We don't call them spastic. We call them intellectually challenged. Well, then that developed the stigma. Then now we call them learning difficulties. Well, that got the stigma. So now we say they're neurodiverse. It's, the stigma follows. You've just got to get people, you've got to get it out there and talked about. And then the stigma will come down, and stigma against mental health will always be an issue. Now, when they come into treatment or they get referred for treatment, the first thing we say is, terrible term, hate the name personality disorder, wish it could go away, can't make it go away, so let's just formulate. We're psychologists, we just go straight for, let's figure out what are your problems, where did they come from, where are we going, and let's just, the label is not relevant to us. It's the behaviors, where you've come from, where you're at, and where you're going that's relevant, a standard formulation. Now, let me tell you, we have a service user reference group, very vocal, very involved, who said, well, actually, it was really, really nice. I mean, we've had this probably thousands of times. We treated close to 20,000 patients. My service is really big. We treat 400 at any given time, and we've been open for 20 years. We've had thousands of people say to us, thank God somebody could actually tell me what's wrong with me. I've had 12 different diagnoses. I felt like I had something, nobody knew what it was or how to treat it. And we say, well, this is what we think it is, it's just an opinion, and here's the treatment. And here's the evidence for it. Shall we get on with it and ignore the label? So that's another one. And the other thing that my clients say is, well, it was really nice once I knew what I had. I could go out and go to chat rooms. I could find self-help books. I could find out there's a world of people out there who have what I have. And individuals tend to let go of the stigma. Systems, in DBT, that's structuring the environment. I will educate. I will go and teach. Anybody who invites me to teach DBT, I'm off. And there I am, and my staff. We probably, each of us, I have 23 staff, and I say at least one of us is teaching every single week on personality disorder and DBT, but mostly personality disorder, saying it's just a label for a constellation of behaviors and reactions. So does that help?
I actually do have a borderline personality disorder label, and I was really, really pleased to have that, because from that moment on, I was taken seriously and looked after, and I had an explanation for myself and for other people. Whether they chose to take it on was another thing. But my question actually is about one of the last slides you showed was about autism spectrum disorder. Now, I work in a disability school, so I'm with adolescents, and they've got all their adolescent stuff going on, but some of them are non-verbal.
Right.
They have huge problems. They're not just neurodiverse, there's a bit more to it. How would this
Yeah.
realistically help those people?
You've highlighted a missing sentence, absolutely. It's, DBT has an evidence base for the higher functioning ASD, more at the Asperger's end, where they are completely confused by people's emotions. They find it difficult to read emotions on people's faces. They don't know what's going on. They're confused. They also are very confused about relationships. And they haven't, that learning history has been problematic all along because of their difficulty in reading emotions. And so DBT is perfect for people like that. We teach them, we just slow it down. I usually double the length of treatment and just take it much slower. And I literally teach them, when a person is feeling this emotion, this is what happens to their eyes, their face, their voice, and so on, and they learn by rote memory. Whereas I can look at somebody and see a bit of confusion or a bit of irritation. I can do that automatically, not being on the ASD spectrum, but that bit of the brain just isn't there, but they can learn it. So it's for the high functioning. You can't do DBT with somebody who's non-verbal. Having said that, you can do DBT all the way down to 5 years old. Francesca, something or other surname, offers DBT to 5 to 8-year-olds. So yeah, you're right. And on the learning disability side, I would have a look at Julie Brown's book, The Emotional Regulation Skills System. The handouts are lots of emojis and pictures, very simplified. If you go to the Society for DBT website, there's lots of LD teams in the country who've turned the handouts into Makaton and so on. We've simplified it way down for people with learning disabilities. But again, rarely would you see somebody with a WISC IQ below about 62. Then it's just too far beyond them. I'd be moving to more of a behavioral treatment rather than DBT, which is very cognitive.
Okay, that's 12 o'clock. That's time for lunch.
I'm okay with one more question if you are.
We'll take one more then. Okay.
By the way, I won an award in April at the DBT Trainers Conference for the person most likely to continue teaching way into the night. One more.
Oh, thank you. I sort of have suffered with trauma, and I now have been with Solent Mind. Anyway, when I started with Solent Mind, it was just like I was a psychotherapist and doing the counselling one-to-one. But then I was introduced to this therapy called Life Decider. And I sort of went in the schools with it. But just expressing that for my own personal life, I didn't experience anything like that, as you were saying in the talk, and it really helped me. And I just sort of thought, wow, this is amazing. Now, my friend invited me here today. I didn't even know what dialectical meant. And I just asked her, but I'm being honest, it sounded confusing. I got the behaviour therapy straight away, but what is that? So she's going to tell me in a minute, but that's not the reason I'm sort of speaking here. It's that I just found what I did with Solent Mind to do with Life Decider was such life-changing for my own self and my family, and saw how it worked in the schools, that this is like, wow, buzzing me now. And my question is, I would like to do this, but where can you advise where to go to get that teaching?
On the first slide, they're going to get the slides, right? Yeah, Lolly said you'd have the slides in advance, but you get access to the slides. On the very first slide, there's a website for where you can go and learn about DBT, and there's all different steps. You can do 2 days of DBT skills and just spend 2 days learning the skills. You can do an extended skills. You can then, depending on your occupation and your core profession, you can go on to do foundation and intensive training. So there's lots and lots of training options available through British Isles DBT is the one I work for, but there are other training organisations. There's APT and others. If you Google training in DBT UK, you'll probably get about 10 different organisations that offer training. I can only highlight the one I work for, but other people work for other ones. So there's a conflict of interest there.
Brilliant.
Since it's on the tape.
Thank you very much.
You're welcome. Right. You're welcome.
John, that was world class. Thank you very much. Really appreciate it.